Um, this slide deck was built with many other slides that I obtained from resources from South Central AIDS Education and Training Center. So just wanted to highlight that this is a collaborative effort, but I don't have any conflicts to declare. Today, we will try to cover as much as we can regarding the strategies to deliver bad news, identify best practices for giving an HIV and hepatitis diagnosis, and describe people first language and effective communication tools for people with HIV and hepatitis. So delivering bad news, developing skills to deliver bad news, not just in healthcare, but in life in general, it can be extremely important in order for us to provide an effective diagnosis and allow the patient to get successful treatment and long-term follow-up. And it's really hard to develop the skills, and it takes a lot of pausing and looking back at how it could have been done better. So I try to be very critical about this in my daily practice. And unfortunately, we deliver bad news in healthcare all the time. So these are, for better or for worse, these are skills that we must develop. And there's a few tools that you can use to excel at it and to make sure that you're providing everything you need, everything the patient needs for this very critical time that can really be life-changing. So one of the important factors for delivering bad news is to make sure that we're doing every effort to deliver the news in person. And this can be difficult, especially with the current practices in healthcare. But it's really a significant difference in terms of what patients experience when they get it over the phone or even through a computer versus when they get it face to face with a face to face interaction. So that's something that we should try and accommodate as much as possible. Many clinics have a setup where they have a kind of frozen slots or protective slots for urgent visits, and that's usually the ideal approach, is that we're protecting those slots for urgent visits, but also to bring these patients for an in-person delivery of bad news or updates. And then so many of you have heard of different protocols that we can use, different mnemonics that we can use to remember. And these are evidence-based strategies that have been proven to make the delivery, the breaking the bad news more effectively. So the BREAKS protocol is one of them, and this was developed by a group of investigators in India and Nepal. And then many of you have heard of spikes. We'll talk about spikes in just a second. They're both very similar. So BREAKS stands for background. So understanding the patient's history, background and support person, their cultural and ethnicity background, their knowledge in their do they know how to read? Do they know what do they do? So understanding the patient's background will really help you develop a better relationship with the patient and a more effective diagnosis delivery. But it's understandable that this cannot always be done depending on the practice or depending on the diagnosis. I cannot tell you how many patients they're sent to my clinic for a management of, for example, syphilis, and then I tell them, do you know why you're here? And they have no idea. So I have to do my best to assess their background during that time frame, and that can be limiting. Report is the next one, and this is allowing space in the environment for the release of the news, but also to understand the concerns. And then explore is the next one. So this is determining understanding. And then many patients will actually depending on the setup, many patients will have some sort of an expectation of what you're going to disclose. So this is our time to explore that. What do you understand is going on with your health? What tests have we obtained? Um, what do you understand big picture that might be going on with your health? And you'd be surprised many patients would already expect, oh, yes, well, I know that I've had some risky exposures and I think I know what I'm going to hear from you. And then sometimes that really alleviates some of the stress in the provider because the patients might already expect the diagnosis. But the E also stands for exploring the patient's willingness to hear the diagnosis and their readiness to hear the diagnosis. And then this is something that we often forget and we just kind of take for granted because the patient is here and we figure they'll want to know. But it's best to explore. I have the results of your laboratories. Would you want to go over those results right now? And then this has never happened to me that a patient has declined to hear the results, but it can happen. Maybe that, hey, I'm really not ready for it today. Can we talk about it in another visit? So exploring whether they're ready for the release of the news is going to be important. Then you announce the news and then you use non-medical language. You try to release at most 3 pieces of medical information because it's hard to process more than 3 pieces at once. And then you pause and then you allow for the patient's emotions. And then so that is the next letter and it's K, it stands for Kindle. And then so the patient's emotions obviously depends on each patient. It can go anywhere from silence, denial, tears. Some can even try to use humor as a coping mechanism. But this is a time to pause and ask them, how do you feel? And I understand this is a difficult diagnosis and show empathy and then expressing their emotions and allowing for some time for reconciling those really strong emotions. And then this is followed by a summary of the diagnosis and the next steps. Ideally, a written summary if possible, because sometimes it's really hard to remember all of those details that were discussed. And then so having some written information can be helpful. Spikes is very similar. And so it starts by setting up the stage. So that's essentially the environment and then understanding the perception. So that is the background that we talked about. Invitation. So this one puts a lot more emphasis on addressing whether a patient is ready for the diagnosis. So in breaks, the invitation would be the E, which is explore. Then knowledge, which is delivering the news, addressing the emotions, and the summary. So they're essentially very similar. Which one's best is whichever you like better as a provider. To be honest, the one I can remember more often is spikes, but it doesn't necessarily mean that it's better, that the other one is just kind of a common practice. Choose one and stick with it, and every time you have to deliver bad news, try to reconcile and see what could have been done better, and then you will excel these skills over time. So this is just a summary of some of the points that we discussed: demonstrating empathy, building a relationship, understanding their perspective, and this might take longer than just a single visit. Speaking in plain language, avoiding kind of doing this whole lecture about the diagnosis that you're providing in that moment, schedule enough time to answer their questions, and then optimizing the next visit and just kind of setting up the stage for the future visits. And then so these are going to be a few tips about communicating results, specifically on HIV and hepatitis. So for the diagnosis of HIV, again, we use our delivering bad news protocol, whichever you prefer. But these are 5 steps that I always try to make sure that I am telling the patients when I'm delivering a new diagnosis of HIV. And I have to be very intentional about reminding myself that even though we've had great progress in terms of options for treatment and prevention of HIV, that we don't live in the 1980s anymore, and that the majority of my patients take 1 pill once a day and see me every 6 months and live normal, healthy lives, that it's still a life-altering diagnosis. And we want to keep in mind that we don't want to minimize what they're going through, that this is something that affects them in every single aspect of their lives. And this is something that I try to be very intentional about when I'm releasing the diagnosis of HIV. So we want to explain that it's a chronic disease and there's no official cure for it. Yes, some people have been cured of HIV, but that is through very complex medical interventions that are not available. And we can have an entire talk about that. So by all purposes, this is a chronic disease, and that is managed as such with medications long term. But it's important to remind them that there's an excellent life expectancy with treatment, especially if they were diagnosed early. And then so there's studies that have compared life expectancy in people who started treatment and continued it long term. And they found that the life expectancy, as long as you're diagnosed early and are adherent to your treatment, is just as good as someone without HIV. And this is very powerful. Then we review transmission risks. And I include U equals U in this subject. So U equals U means undetectable is untransmittable. I tell them once the virus is suppressed, it cannot be transmitted to your loved ones through sex. And this is very, very powerful. And especially because I tell them you will not hurt others as long as you're taking your medications and we're keeping a close eye on the laboratories. Explain the treatment that will be started as soon as possible and that we're going to expedite it. Historically, there were all of these processes to meet criteria for treatment, but nowadays we meet criteria for treatment initiation of antiretrovirals as early as 72 hours after the diagnosis, so as early as possibly can. We want to emphasize that we need to expedite treatment initiation, and this is with the purpose of not only alleviating their anxiety, but reducing the risk of transmission to others. And then I review HIV transmission, and I think there's a lot of times when we just take for granted knowledge about this, and you would be surprised of how many times patients won't ask me until I tell them. So I go over the fact that they will not transmit HIV through kissing, through hugging, sharing utensils, sharing plates, sharing meals with their family, sharing the restroom, or even through mosquito bites. And after that, I've seen so many patients just like light up. And they just wouldn't bring up that concern because they just either had an assumption or they were too afraid to ask. So making sure that you're not making an assumption and that you start from the get-go and you tell them if you don't want me to go over this, if you're not ready to go over this, we can skip it. But I just want to make sure that you know of the things that will actually put you at risk of transmitting the infection. This is a reminder that undetectable is untransmittable, and this is specifically for sexual exposures. And then so once the virus is undetectable, it cannot be transmitted to others. By all purposes, the studies that looked into this, their definition of undetectable was less than 200 copies per ml. So this can be also a little bit of a sensitive subject because some of the laboratory techniques that we nowadays have can be just extremely sensitive. And then so they might detect some particles of virus, but it might be below the level of quantification. And then some patients will freak out when they see this, especially now that we use like patient portals, and they'll see the results and they say, oh no, I'm no longer undetectable, but it says detectable, but the viral load is less than 20. So I go over it with them up front. Is by definition, the U equals U is really below 200 copies per ml. And it's not, don't freak out if you see it in the laboratory, they're reporting it as detectable, but unquantifiable. So those are kind of just tips specifically for HIV. With hepatitis C, a reminder, so we use two different kind of screening tools for it. We use the antibody-based test, and then for antibody is a really good test, but just know that there's going to be some limitations if you had a recent exposure. So this is why in an ideal world, we want to make sure that we're ordering antibody with reflex to RNA, because if your antibody is positive, then you don't have to have the patient go back to the laboratory to get another blood draw. It just kind of reflexes automatically to the RNA. But if you have a negative antibody, then this is a reassuring test, and then we will need to address the risk of exposure in the last 6 months and consider the need for ordering an RNA. Now, if you have an antibody positive with a negative RNA, this is a reminder that there's no active infection currently, but this patient had hepatitis C in the past. They could have cleared it spontaneously, which happens in a proportion of patients, or they could have cleared it after prior treatment. And then so it's an opportunity to ask the patients and see if they got treatment in the past. But it's also an opportunity to address risk factors, and then also to make them aware that their antibody will be positive for the rest of their lives. So don't freak out if your laboratory is again in the future showing a positive antibody. That's expected. We will screen you in the future with an RNA only. And then if you have a detectable RNA, then this means that there is evidence of current or active infection, and this warrants treatment. And this is when we explore all the best next steps for treatment, but we will explore also risks of acquiring it again in the future and ways to mitigate that. We have had a separate talk by Dr. Gonzalez specifically about risk of transmission of hepatitis C, so I won't get too much into the details of this. Just note that this talk is available. But just as a reminder, this is what we tell our patients. Hepatitis C can be cured, but it can be acquired again. Having an antibody will not give you immunity. So we have to address their risks of acquiring it again. We explain the difference between antibodies or serologies and viral load. We reviewed transmission and transmission risks, and we always discuss additional strategies to maintain liver health, explore their alcohol use, if they're immunized or vaccinated against hepatitis B and hepatitis A, and then if they have hyperlipidemia or metabolic syndrome and other potential factors that will put them at risk of developing a metabolic associated liver disease. A reminder that hepatitis C, it's a very sturdy, resilient virus, and it can live in surfaces for several days. So remind the patient that it's not only IV drug use that puts them at risk of acquiring hepatitis C in the future, but also snorting cocaine, for example, in surfaces that were shared with other people. It can live on those surfaces for 16 days, and then so there can be some breakdown of the nasal mucosa, and that is a common known way that hepatitis C can be transmitted. So addressing, not just making an assumption that it was related to IV drug use, but addressing their risk based on cocaine use as well. Remind our patients that there's no vaccine for it, unfortunately, for many reasons. But there is a vaccine for hepatitis A and hepatitis B, and we want to make sure that we're offering this for them to prevent additional insults to their liver. And then so infection does not always lead to chronic disease, but repeated exposures can do so. So always extremely important to address the risks. For hepatitis B, it's a little bit more complicated. And the reason is that there's, for many reasons, and then the nature of the virus, there's no medications that I can give you that will actually cure the hepatitis B infection. In this case, we will only reach to essentially functional cure once the host develops immunity to control the virus. And that doesn't always happen. So once someone has developed chronic hepatitis B, then that's something that it's very rare for that to happen. And the likelihood of someone to develop immune control for hepatitis B depends on many different factors: ethnicity, the age at which they acquired the infection. So people or babies who acquired the infection early have a much higher risk of developing chronic hepatitis B infection, and then their immune system. And just know that also, even if you develop immunity, you can lose it later on. So the disclosure can be a little bit more complicated, and having patients understanding this can be a little bit challenging. So then again, we want to make sure we're testing pregnant women and that we're offering babies both hepatitis B vaccine and hepatitis B immune globulin at the time of birth, and addressing the risk of transmission to others. And I remind them, hepatitis B, so the majority of patients I serve are people living with HIV. So I tell them hepatitis B is 100 times more contagious than HIV. And there's actually a tool that we have for prevention that is very effective, which is a vaccine. So I remind them of that. But I remind them about how to protect their partners, so barrier methods, but making sure that their partners are offered the vaccine. Refrain from sharing items such as toothbrushes, razors, nail clippers, earrings, personal infection equipment with everybody, with other household contacts. Do not donate blood. And then the things that will not transmit the virus: kissing, hugging, coughing, sharing food, or casual contact. A reminder that stigma perpetuates health disparities and epidemics, and it's important that we are intentional about identifying our own stigmas and sometimes unconscious bias. There's a lot of available tools to identify unconscious bias internally, and I welcome you to look at this online. But stigmatizing a patient or a condition will only lead to lower chances of a patient to seek medical treatment and higher risk of transmission of the infection to others. So making sure that we are addressing stigma internally. And one of the most important tools to address stigma is to use people first language. And what this is putting the person first and not their condition or diagnosis. For example, Jack is not homeless, but a person experiencing homelessness. So the person goes first. John is not diabetic, but a person diagnosed with diabetes. And so forth and so on. And then so specifically for HIV, now we say this person is a person living with HIV. We don't call them HIV positive, HIV negative. We say someone living with HIV. And then the patients can also be very sensitive about advanced HIV disease diagnosis. So what we call AIDS, it can really cause a lot of trauma for them when we are using that word. So we can tell them the infection is advanced, or CD4 is pretty low. And then so that can be a little bit easier to digest. And then I try to take every opportunity that I have to educate others about using non-stigmatizing language for these patients, because it makes or breaks the relationship for the patients. Without getting too much into the details, something that I hear very often and still, unfortunately, is using the phrase drug abuse or IV drug abuse. You know, we don't abuse a drug. The drug is not a person to be abused. So the right term to use is substance use disorder, and I'm always very intentional about identifying if someone is documenting terms that can be perceived as stigmatizing, to make sure that we're giving them feedback. A laboratory result cannot be clean or dirty. And this happens often when people ask me about a urine test. The urine test was dirty. What does that mean? Does that mean that it was contaminated, or does that mean that it was showing infection? So I tell them, do not use those terms. Some patients might mention, I've been clean for X amount of time, but that's not an excuse for us to use that again, because it is also a stigmatizing term. And then, so in the interest of time, I will skip the rest of the slides, but there are some, and the slides can be available to you. And these are going to be some additional recommendations to for any clinic setting, kind of how we can overcome some of the challenges in terms of making sure that you're using an anti-stigmatizing language and a language that will best serve your patients. So I welcome you to review the slides afterwards, but I will now stop the share and allow for questions.